Hello and welcome. Today we're going to tackle a really critical topic, pressure injuries. Over the next few minutes, we're going to create a super clear visual guide that'll help you spot, stage, and manage these common but really serious wounds.
So let's just dive right in with a question that every single clinician runs into. You see some red skin on a patient. Is it just, a little temporary irritation? Or is it the very first sign of real tissue breakdown, a stage 1 pressure injury? Stick with me because by the end of this, you'll know exactly how to tell the difference.
Okay, first things first. We have to understand the fundamentals. Where do these injuries usually show up, and what's really causing them? Well, it all boils down to one thing: sustained pressure.
Right, so pressure injuries almost always pop up over what we call bony prominences. Those spots where bone is super close to the skin without a lot of cushion. This slide shows you the biggest hot spots we need to be checking all the time. The lower back and tailbone, the heels, hips, shoulders, and yep, even the elbows. So now that we know where to look, the next logical question is who? Who is most likely to get these injuries in the first place?
So the key is spotting these risk factors early. Being stuck in bed, that prolonged immobility, that's the big one, for sure. But we also have to be really on top of things like incontinence, which can just wreck skin integrity, and poor nutrition, because it starves the body of the very things it needs to repair itself. And then you have conditions like diabetic neuropathy or liver issues that put patients at an extremely high risk.
To make this less of a guessing game, we use a standardized tool called the Braden scale. Just remember BS. But seriously, this isn't just about paperwork. It's our roadmap for prevention. It's a scoring system that looks at things like moisture, mobility, and sensory perception to put a number on a patient's risk. And remember, a lower score means a higher risk, which tells us exactly who needs our attention the most.
All right, this is the real meat and potatoes of our explainer. We are going to visually break down how a pressure injury progresses, layer by layer, from just a surface-level warning sign all the way down to deep tissue damage.
The easiest way to think about it is like a 4-step journey, and that journey is always downward. It starts at the surface, then it actually breaks the skin. From there, it can dig down into the fat, and in the worst cases, it goes all the way down to the muscle and bone.
And here we go. This slide right here answers our big opening question. The key identifier, the magic word for a stage 1 injury, is non-blanchable redness. What that means is when you press on the red spot, it doesn't turn white for a second. The top layer of skin, the epidermis, is definitely damaged, but, and this is key, the skin is still intact. It's not an open wound yet.
Okay, so in stage 2, things get real. We now have the first actual break in the skin. The damage has pushed through that outer layer and is now into the dermis below. The wound itself often looks red or pink, maybe a little shiny. This is officially an open wound.
Now, stage 3 is where the damage gets much, much deeper. We're talking full thickness skin loss that goes right into the subcutaneous fat tissue. And a really dangerous thing can happen here called tunneling. That's where the wound can actually start burrowing underneath the skin you can see, creating these hidden pockets of damage.
And here we have it, the most severe stage. Stage 4 is full thickness tissue loss, where you can literally see or feel muscle, bone, or tendon right there in the wound. The damage is just massive, and the risk of a very serious infection is incredibly high. Now hold on, it's really important to know about this separate category, the deep tissue injury. This one can be super deceptive, because the skin on the surface might look totally fine, but there is significant damage happening way down below. You want to look for a dark purple or maroon-colored area. It's a huge warning sign that there's major trouble brewing underneath. So what happens when you're looking at a wound but you can't actually see the bottom of it? Well, that brings us to a really common clinical problem, the unstageable wound.
Basically, a wound is unstageable if the base is all covered up by either eschar or slough, making it totally impossible to see how deep it really is. Here are a couple of great tricks to remember the difference. Eschar is that hard, black or brown dead tissue. Just think charcoal. And slough, that's the yellow, kind of stringy tissue that, well, it can look a bit like cooked chicken skin.
And this leads us to a non-negotiable clinical rule. You absolutely cannot accurately stage a wound until it's been debrided, which just means that all that dead tissue has been cleaned out. You simply can't stage what you can't see.
Okay, so we've covered how to identify and stage these injuries. Now let's pivot to the most important part, right? The action plan. What do we do to prevent and treat them?
These are the fundamentals, the absolute must-dos. You've got to assess and document your patient's skin within the first 24 hours. You have to reposition them every 1 to 2 hours to get that pressure off. And you need to push nutrition, especially protein and lots of fluids. And of course, constantly monitor any wounds that are already there for any changes in stage, size, or color.
All right, now let's focus on 2 numbers that you absolutely have to know. The first one is a range, 3.5 to 5.0. Seriously, if you remember only one lab value for wound healing, make it this one.
That's the normal range for serum albumin. Albumin is the key protein our bodies need for all that tissue repair and rebuilding. Think of it like the construction crew for healing. If your patient's albumin is low, their ability to heal is going to be in big trouble.
Okay, here's the second critical number, and this one is a huge red flag. A urine output of less than 30 milliliters per hour.
When you see a number this low, alarms should be going off in your head. It's a massive kidney distress signal. It means things aren't getting perfused properly, and you could be heading toward organ failure. The body is in crisis mode, and it's going to shut down anything non-essential, like wound healing.
So let's wrap this all up and put it into practice. Imagine this. Your patient has a stage 1 injury on their hip. You've done your assessment. What is the single most powerful